Welcome back to PNB Wellness Academy. I'm Dr. Krista Lewis, and today we're making lithium simple for the PMHNP boards. Lithium is one of those medications you definitely need to know because board questions can test its indications, therapeutic levels, monitoring, adverse effects, drug interactions, pregnancy considerations, and toxicity. My goal is to help you recognize the key clues quickly and connect them to the correct answer. Let's get started. Lithium is considered a gold standard mood stabilizer for bipolar disorder. It is used in the treatment of acute mania and for maintenance treatment of bipolar disorder. One of the most important lithium facts for your boards is its ability to reduce suicide risk. So when you see a patient with bipolar disorder and the question emphasizes mood stabilization along with suicide risk reduction, think lithium. Lithium has a narrow therapeutic index, which means there is a relatively small difference between therapeutic and toxic concentrations. A general therapeutic range commonly taught for board review is approximately 0.6 to 1.2 milliequivalents per liter. The exact target varies based on whether lithium is being used for acute treatment or maintenance and on individual patient factors. Toxicity becomes increasingly concerning at approximately 1.5 milliequivalent per liter and above. However, don't rely on the number alone. A patient with clinical symptoms of lithium toxicity requires evaluation even if you're given a level that doesn't appear dramatically elevated. Now, you want to remember the 12-hour trough. A very important board pearl is the lithium levels are generally obtained as a 12-hour trough. This means the blood level is drawn approximately 12 hours after the last dose. Lithium generally reaches steady state in about 5 days. So after initiating lithium or changing the dose, a lithium level is typically obtained after steady state has been reached. Once the patient is stable, continue periodic lithium levels along with renal, thyroid, and other appropriate laboratory monitoring. For the boards, you want to connect that lithium has a narrow therapeutic index, and then you have a serum level monitoring of 12-hour trough. Before starting lithium, think about the organs and system lithium affects. You want a baseline renal function, thyroid function, calcium, electrolytes, and pregnancy tests when applicable. An EKG may also be appropriate when clinically indicated, particularly in patients with cardiovascular disease or significant cardiac risk factors. Renal function is especially important because lithium depends on the kidneys for elimination. So you want to check the BUN, the creatinine, and the hepatic glomerular filtration rate as appropriate. You want to check the TSH because lithium can cause hypothyroidism. You want to check calcium because lithium can cause hyperparathyroidism and hypercalcemia. And obtain a pregnancy test when applicable because lithium exposure during pregnancy has a classic board association with congenital cardiac abnormalities, particularly Epstein anomaly. This is one of the most important lithium concepts for the boards. Lithium is not metabolized by the liver. It is primarily excreted unchanged by the kidneys. Therefore, decreased renal function leads to decreased lithium clearance, and that increases lithium concentration, which can cause increased toxicity risk. This is particularly important in older adults because declining renal function can reduce lithium clearance and increase the risk for toxicity. Lithium can also affect the kidneys over time. So long-term lithium therapy can contribute to chronic kidney disease, which is the one reason renal function must continue to be monitored throughout treatment. Another classic lithium adverse effect is nephrogenic diabetes insipidus. If a patient taking lithium develops polyuria and polydipsia, think nephrogenic diabetes insipidus. Another major lithium association is hypothyroidism. This is why we obtain baseline thyroid function and continue monitoring TSH levels during treatment. If a patient is taking lithium and they develop symptoms such as fatigue, weight gain, cold intolerance, and other symptoms suggestive of hypothyroidism, check the thyroid function. An important clinical and board concept is that developing hypothyroidism does not automatically mean lithium has to be discontinued. Hypothyroidism can often be treated with thyroid hormone replacement while lithium is continued, when lithium remains clinically indicated. Previously, we mentioned how lithium exposure during pregnancy can result in birth defects like Epstein anomaly. Epstein anomaly involves downward displacement of the tricuspid valve. A useful memory connection is lithium equals low implanted tricuspid. Clinically, pregnancy management is more nuanced than simply labeling lithium absolutely contraindicated. So treatment requires an individualized risk-benefit assessment. But when answering a traditional board-style association question, lithium and Epstein anomaly is the connection you need to recognize. Avoid and. Here is one of the easiest lithium interaction mnemonics to remember. ACE inhibitors and ARBs, NSAIDs, diuretics, particularly thiazide diuretics. So you want to remember avoid and. These medications can decrease renal lithium clearance, which can increase serum lithium concentrations and increase the risk for toxicity. Imagine a board question telling you that a patient has been stable on lithium. The patient develops hypertension and is prescribed a thiazide diuretic. Shortly afterward, the patient develops worsening tremor, confusion, and ataxia. Your connection should be thiazide, decreased lithium clearance, increased lithium level, and lithium toxicity. Sodium and hydration is another extremely important lithium concept. Dehydration can increase lithium concentration and increase the risk of toxicity. Sodium depletion can do the same thing because lithium and sodium are handled similarly by the kidneys. When sodium is depleted, the kidneys may increase lithium reabsorption. So for boys, you want to remember dehydration or sodium depletion, your lithium level increases and toxicity risk goes up. Patients taking lithium should generally maintain consistent fluid and sodium intake. Pay attention when a board question mentions vomiting, diarrhea, fever, excessive sweating, dehydration, or a major change in sodium intake in a patient taking lithium. Those aren't random details, they're clues. Know the major adverse effects associated with lithium. A fine hand tremor can be a common adverse effect. Other effects include GI upset, weight gain, polyuria, polydipsia, and cognitive complaints. The major organ associated to remember are thyroid, kidneys, parathyroid, because the thyroid can result in hyperthyroidism, kidneys can result in nephrogenic diabetes insipidus and potential chronic renal impairment, and the parathyroid can result in hypoparathyroidism and hypercalcemia. Lithium can also cause leukocytosis, which is typically benign. Now you want to know the difference between a fine tremor and a coarse tremor. This distinction is particularly useful for board questions. A fine hand tremor can occur as a common lithium adverse effect, but a coarse tremor, particularly when accompanied by neurologic symptoms such as ataxia, confusion, slurred speech, should make you concerned about lithium toxicity. So remember, fine tremor is a common adverse effect, but a coarse tremor plus ataxia, confusion, you want to think toxicity. Lithium toxicity may present with nausea, vomiting, diarrhea, weakness, and worsening tremor. As toxicity becomes more significant, neurological symptoms become increasingly important. You want to look for coarse tremor, ataxia, confusion, and slurred speech or dysarthria. Severe toxicity can progress to seizures, severe altered mental status, coma, and other serious neurologic or cardiovascular complications. So if a board question gives you a patient taking lithium who develops significant GI symptoms followed by a coarse tremor, ataxia, and confusion, recognize lithium toxicity. Another point worth knowing for boards is that severe lithium toxicity may require hemodialysis. Lithium is dialysable, so hemodialysis may be used in severe poisoning, particularly when there are serious neurological manifestations, impaired renal functioning, or markedly elevated concentrations in the appropriate clinical setting. So if lithium toxicity is severe, you want to think hemodialysis. Now, older adults deserve special attention when lithium comes into play because renal function often declines with age. So when you have an older adult, you want to remember decreased renal functioning, decreased lithium clearance, increased lithium concentration, which is an increased risk for lithium toxicity. If an older adult has been stable on lithium and suddenly develops toxicity, look for changes in renal function, hydration status, sodium balance, and interacting medications. Before we finish, make these lithium associations automatic. Lithium is a gold standard mood stabilizer for bipolar disorder and is especially important because of its ability to reduce suicide risk. Lithium has a narrow therapeutic index, so levels must be monitored with levels generally obtained as a 12-hour trough. And the therapeutic level is 0.6 to 1.2 milliequivalents per liter. Lithium is primarily excreted unchanged by the kidneys, so decreased renal function decreases lithium clearance and increases the risk of lithium toxicity. Remember, ACE inhibitors, ARBs, NSAIDs, and diuretics, especially thiazide, can increase lithium levels. Dehydration and sodium depletion can also increase lithium levels and toxicity risk. A fine hand tremor can be a common adverse effect, but a coarse tremor with ataxia and confusion should make you think lithium toxicity. Polyuria and polydipsia may point toward nephrogenic diabetes insipidus. Also remember lithium's association with hypothyroidism, hyperparathyroidism, and hypercalcemia, and potential chronic kidney effects with long-term use. In pregnancy, remember the classic board association with Epstein anomaly. And finally, severe lithium toxicity may require hemodialysis. And that's Lithium Made Simple for PMHNP boards. If you remember nothing else, remember the major connections: bipolar disorder, reduced suicide risk, kidneys, thyroid, the 12-hour trough. The therapeutic level is 0.6 to 1.2 milliequivalents per liter, and avoid and that's ARBs, ACE inhibitors, NSAIDs, diuretics. Make sure you have good hydration and sodium intake, and you need to know how to recognize toxicity. Thank you for learning with me today at PMB Wellness Academy. Save this video for your board review and subscribe for more PMHNP board prep made simple. I'll see you in the next review.